Our next plenary session is going to be on rheumatoid arthritis. We are delighted to invite Dr. Kamran Hamid, Associate Professor and Head of Department Rheumatology at Aga Khan Hospital, Dar es Salaam, Tanzania, Professor Dr. Sumaira Farman Raja, Chairperson Scientific Committee PSR 2025 and Head of Department Rheumatology National Hospital, and Professor Samina Ghazanvi from South City Hospital, Karachi, along with Dr. Yasir Imran, practicing rheumatologist at King Edward University as co-chair.
Rheumatoid arthritis is a debilitating disease that continues to affect countless lives and challenges clinical management. We have with us an awareness video prepared by Hirani Pharma in collaboration with PSR to shed light on the important condition. I would now request everyone to watch this video.
Life. How much do we know about it? हर पल बदलने वाली ये लाइफ हमें रोज कुछ नया सिखाती है, एक नई उम्मीद देती है। पर कभी अचानक ही यही लाइफ कोई ऐसा मोड़ लेती है जो ना समझ आता है ना ही संभल पाता है। आपकी अपनी ही बॉडी खुद के खिलाफ लड़ जाती है, उंगलियों के जोड़ दुखने लगते हैं, घुटनों में तकलीफ की वजह से उठना बैठना चलना फिरना दुश्वार होने लगता है। कलाइयों में ऐसा दर्द होता है कि रोजमर्रा के काम किसी जंग से कम नहीं लगते। मॉर्निंग स्टिफनेस इन जॉइंट्स, और वो भी ऐसी कि बिस्तर से उठना नामुमकिन सा लगता है। लोग कहते हैं उम्र का असर है, लेकिन ये कंडीशन र्यूमेटॉइड आर्थराइटिस भी हो सकती है, an autoimmune disease that starts the fight within. It results in inflammation leading to redness, tenderness and swelling of the joints. और अगर इसको ज्यादा लंबे अरसे तक नजरअंदाज किया जाए तो ये जिस्म के अहम तरीन आज़ा को मुतासिर कर सकता है। ये बीमारी जिंदगी को मुश्किल कर देती है। बट लाइफ इट्स स्टबर्न। हम समझकर, समझाकर और मिलकर र्यूमेटॉइड आर्थराइटिस को पहचान सकते हैं। We can put up a fight and together we can win. र्यूमेटॉइड आर्थराइटिस सिर्फ जोड़ों की ही नहीं बल्कि जिस्म के मुदाफ़ियती निज़ाम की भी बीमारी है। ये मर्दों के मुकाबले में औरतों में 3 गुना ज्यादा पाई जाती है और उम्र के किसी भी हिस्से में हो सकती है। इसका बरवक्त और दुरुस्त स्पेशलिस्ट यानी र्यूमेटोलॉजिस्ट से इलाज का ना मिलना माजूरी और बाज़ औक़ात पेचीदा सूरत हाल में मौत का बायस भी बन सकता है। र्यूमेटॉइड आर्थराइटिस के कई मौसर इलाज मौजूद हैं। ज़रूरत इस बात की है कि हम सब मिलकर इस बीमारी के खिलाफ आगही को मुमकिन बनाएं और इस बीमारी को शिकस्त दें, जिसकी बदौलत बिलखुसूस हमारी माएँ, बहनें, बेटियां बेहतर जिंदगियां गुजार सकती हैं। मैं हूं टीपू शरीफ और मैं र्यूमेटॉइड आर्थराइटिस के खिलाफ इस जंग में आपके साथ हूं।
What a wonderful message. So the first speaker for this session is going to be Dr. Fariz Yahya, consultant rheumatologist at the University of Malaya, Malaysia. Today, he will be presenting on tailoring treatment in rheumatoid arthritis, case-based discussions. Please join me in warmly welcoming Dr. Fariz Yahya to the stage.
Thank you very much, and Assalamu alaikum. Good afternoon, everyone. Thank you to the President and Society for the invitation. So my name is Fariz Yahya. I'm a rheumatologist from Malaysia, Kuala Lumpur. And it's great to see everyone here. So what I'll do today is I'll have some case discussions in terms of how we tailor treatment in rheumatoid arthritis. So there will be 3 cases. I will have some questions. These questions are not actually polling or Slido questions, but questions just to get your thoughts moving. So this is my disclosure statement. Maybe I'll use this. So the drug discovery in rheumatoid arthritis has dramatically changed about over 100 years. And the medications in the 1920s, which include intramuscular GOL, the other traditional DMARDs have used in the past, they have seen clinical benefit in patients about 100 years ago. But things have changed since the development of biologics. We have multiple biologics now, especially for rheumatoid arthritis, and they're very focusing on specific targets, specific molecules, and even specific interleukin cytokines. And as time goes on, we have further signaling pathway treatment. These intracellular pathways have now made us to have available treatments such as our JAK inhibitors. And not forgetting in terms of imaging as well, we're all starting to use ultrasound when we diagnose and treat rheumatoid arthritis. And in terms of imaging, this is my poor attempt of developing an image using ChatGPT. I think I need to attend an imaging course about developing image using ChatGPT. So this is my first case, 76-year-old female. Basically, she has a diagnosis of rheumatoid arthritis, seronegative. She initially presented with polyarthritis when she was about 50 years. So rheumatoid factor at that time was negative. She had elevated ESR. She had clinical significant synovitis affecting both hands, her wrists, and her knees. And she was started on methotrexate up to 20 milligrams per week. Now, her symptoms of joint pain and her disease was not really in remission. She did have mild persistent symptoms, and she was later added on leflunomide to the methotrexate. So there was a combination of leflunomide plus methotrexate, and her disease was still active despite the conventional synthetic DMARDs. Now, this patient's son was actually one of our respiratory physician, so he made sure that his mom got the best treatment possible. So it's not an easy sometimes when we treat someone you know. And this patient, despite that disease activity, she was started on a TNF, etanercept. This was in 2009. She had improvement in her joint symptoms. She had good clinical response, and she was on etanercept for about 2 years. Unfortunately, she had a secondary loss of response, and we had to switch her to tocilizumab, which is an interleukin-6 inhibitor. And she also had a primary non-response to that. But when we look at this patient again, when she first presented, she had a slightly high BMI, 27.8. She didn't have any other comorbidities. And if we look at her treatment, again, for her rheumatoid arthritis, she had failed one anti-TNF, she had failed tocilizumab, and her DAS28 ESR was still elevated at 5.1. So we discussed with the patient, with the son, and eventually we decided to give her IV rituximab. This was over 10 years ago. Now, her first IV rituximab was 1 gram. And when she had that infusion in the ward, she developed the rash. She felt slightly flush. She had redness over her arms and chest, and her immunoglobulin levels were normal. And this raises the question for thought for everyone. I mean, this patient had a failure to 2 biologics. She is now on rituximab, and she developed this rash with the 1 gram of rituximab infusion. The next step of action could be any of the 3. There's no right or wrong answer. Whether we should control with conventional synthetic DMARDs, triple therapy, should we switch the rituximab back to another anti-TNF, or should we re-challenge rituximab at a lower dose? And what we did, we actually, there's no right or wrong answer, but we did this at that time. So we re-challenged her with a lower dose of rituximab plus methotrexate. And fortunately enough, she did very well with that 500 milligrams at the next infusion. She tolerated that lower dose of rituximab. She did not have any rash. We reduced the infusion rate, and she did very well in terms of a joint and DAS28 response. And what she has in terms of the rituximab, we gave her every 6 months. And then we decided that we'll wait on a bit to 7 months. And then we'll wait on a bit to 8 months. And when we waited about 8 months in the next few infusions, her symptoms started to develop again. She had CRP elevated between 20 to 30, and we decided that she gets that rituximab every 8 months. And post-rituximab infusion, she did very well. Her CRP has always been about less than 3 milligrams per liter. And I saw her last month at our clinic and daycare, and she had her last rituximab in September 2025. So this patient did very well on the lower dose of rituximab. She did not need any infusion at every 6 months. And this is probably one of the patients that you may see in your daily clinical practice. It's not as straightforward as it would seem. But when we talk about in terms of treatment, rituximab in rheumatoid arthritis, we have data from over almost 20 years ago, the REFLEX trial, showing that patients who were on methotrexate plus rituximab did at least better than those who were on placebo. There were significantly higher ACR20 responders for patients who were on rituximab. But then the question remains, what happens after that 6 months? Would they still have the ACR20 response, or would it be significantly less? And now in 2025, if we go back about 3 years earlier, we have these EULA recommendations for rheumatoid arthritis, the 2022 update. And from that recommendation, it has been suggested that biologic DMARDs or conventional synthetic DMARDs, dose reduction or interval increase is preferred, but not advisable to completely stop these medications. And for those of you who attended EULA or APLA Congress recently, the EULA Rheumatoid Arthritis Task Force has decided that they have newer data. The continuation of DMARDs, whether it's traditional synthetic, biologic, or targeted synthetic DMARDs, is recommended. They should be continued. However, dose reduction is something that may be considered. And in this patient, it's not just about reducing the dose, because the question we always get from patients is that, when can I stop my biologic or treatment? And it's not easy to answer that, because especially in this patient who had what we define as difficult to treat rheumatoid arthritis, there are 3 criteria in which we define difficult to treat rheumatoid arthritis. We've been starting using difficult to treat RA in the last few years, and by definition, difficult to treat RA consists of patients' failure of at least 2 biologic or targeted synthetic DMARDs with different mechanisms of actions. They should have presence of active or symptomatic disease, and this includes unable to bring down the steroids, or they have a rapid radiographic progression. And also, I think important here is that the patient or the physician's perception in difficulty in managing the condition. But what's important about difficult to treat RA? Obviously, it's we need to control the disease early. We want to prevent that radiographic progression. What's interesting from this paper, which was recently published just, I think, a few weeks ago, noting that obesity and fibromyalgia may be linked to difficult to treat rheumatoid arthritis. And in this cohort of almost 500 patients, 1 out of 5 patients with rheumatoid arthritis had difficult to treat RA. When they compared patients with difficult to treat RA versus non-difficult to treat RA, obviously these patients had longer disease duration, they had higher disease activity, and obviously because of the failure of biologics, there were more frequent use of JAK inhibitors. But what's, I think, interesting is that obesity and fibromyalgia were also associated with the development of difficult to treat RA. And let's move on to the case number 2. Our second case is a 71-year-old female. She has rheumatoid arthritis seropositive. She was diagnosed in the 1990s, and she has been on methotrexate. She had a gradual escalation of methotrexate as well because of the increasing joint disease. Her methotrexate remained at 20 milligrams per week. And she was quite stable throughout those several years. Until in 2019, she came to our clinic and she had some mild shortness of breath. We had a HRCT done for her, and from the radiologist report, it shows that she has some UIP pattern from the HRCT scan. Her lung function test shows FVC of 90%, which is extremely good for her age. DLCO was acceptable. However, the main issue was that she also had joint pain, which persisted despite being on that methotrexate 20 milligrams. So we gave her IV steroids just to control that joint pain. And this is her HRCT. So if you can see the UIP findings, not very significant. They are probably mild, and her symptoms actually did not come back after the IV steroids. However, when we taper down the steroids, we taper to oral prednisolone again, she still had active disease, just being on the methotrexate, and her disease activity was relatively quite high. Now, in a patient with interstitial lung disease, UIP pattern, which is not that severe, but her joints are quite severe, there are different treatment options, and we have a lecture just now about SARD-ILD, CTD-ILD, and there were options mentioned which include mycophenolate mofetil, whether we should use TNF inhibitors just to target the joints, or should we proceed with rituximab. And we went with rituximab. And she, like the first patient, she also had rash with the first dose, but she wasn't keen to continue with rituximab, and we switched her to an anti-TNF that time, IV infliximab. She did not have any, she did have a primary non-response for the infliximab and also with the IV golimumab, and we switched her again to tafasitamab. Unfortunately, she had some GI intolerance. So finally, we started her on the biologic IV tocilizumab in 2018. She had significant DAS28 improvement. Her joints were very well. She did not have any worsening in her lung function, and her IV tocilizumab remained for over 5 years. So she's been doing very well on it. Unfortunately, last year she developed this gluteal abscess. She was admitted with septicemia and pulmonary embolism, and she unfortunately passed away in 2024. But when we look at the RA-ILD, we had talks recently and also yesterday as well, talking about SAR and CTD-ILD. But let's focus on rheumatoid arthritis ILD itself. If we see this list of preferred therapies, we can see mycophenolate, azathioprine, and rituximab for treatment of ILD. Think, what would we do if this patient has ILD and also have active joint disease? The only option here would probably be rituximab, because we know that mycophenolate and azathioprine doesn't really work well to control the joints. And this is from the 2023 ACR CHEST guidelines. Now, the 2023 ACR CHEST guidelines also mention that the progression of ILD, despite the first ILD therapy, we can also consider the use of rituximab and also tocilizumab. And if you can see from the list here, these are the only two medications that would probably help in terms of controlling the joint symptoms. So the options are fairly limited. And the 2023 ACR CHEST guideline recommends that monitoring lung function tests every 3 to 12 months is preferred, maybe less if they're stable. But if we look at the ACR RA 2021 treatment guidelines, that we can still use methotrexate with patients stable parenchymal lung disease. Because sometimes we worry about the hypersensitivity pneumonitis. I think if methotrexate should be discontinued if there is a concern in these patients. But from this latest 2023 guidelines, it says that we can continue methotrexate in patients with RA-ILD if we need to control that articular involvement. But nevertheless, I think the key here is that evidence saying that controlling articular disease is a key risk factor for developing RA-ILD. And moving on to the final case, this is a 58-year-old lady who we've been seeing in the clinic. She has seropositive rheumatoid arthritis. Her ACPA was very high. Her rheumatoid factor was very high. But what's special for her is that she has secondary antiphospholipid syndrome. She's presented with left leg DVT and has been on lifelong warfarin, and she has been on methotrexate since her initial rheumatoid arthritis diagnosis. Now, with her, there was a bit of an issue because she defaulted her treatment with us. And this was about 10 years. She went to another hospital nearby. There might be several factors, including cost and also education. But when we saw her again, 10 years later, she had multiple joint synovitis. She already had that bilateral hand deformities. She had bilateral knee pain and reduced range of movement. So when we saw her at the clinic, we had to restart her methotrexate. Over time, we combined the methotrexate with various conventional synthetic DMARDs, including leflunomide and sulfasalazine. However, she has failure of all the combinations of CS DMARDs, and she was advised for biologics.
But for her, she refused joint replacement surgery. And if you look at the x-ray, she already has joint damage around her shoulder and also both her knees and also in the right hip. Now, the question here is that do we think that joint replacement surgery would benefit this patient? Well, the easy answer is yes, but sometimes it could be a no because we have to control that disease activity as well. When we advised her for joint surgery, she still refused. She failed that triple therapy, a conventional stentic DMARD. She was relying on steroids, and she still had persistent active disease, eventually had intolerance to methotrexate, and was only left with leflunomide. So we tried several treatments, including adalimumab. Unfortunately, she developed a rash. We tried with IV rituximab. It did help slightly, but there was an issue in terms of getting funding because approval every 6 months is a bit difficult for her, and we also have the delay in getting approval after the application. So finally, this year, we switched her to tofacitinib. And this did her very well because all the joint pain has actually improved. Her DAS ESR was also better than previously. But one of the things, the issue with her, the key issues and challenges with her is that she defaulted treatment in the early part. She defaulted for almost 10 years. And this led to the rapid progression. This led to the deformities and joint damage. And I think patient education is important in this aspect. The other aspect is the socioeconomic and financial constraints. We now have biosimilars. We now have generic JAK inhibitors. And this hopefully can delay or can overcome those constraints. And finally, the refusing for surgical intervention. Sometimes there might be some considerations and some discussion needs to be made by the patient, but there might be better quality of life if she had undergone surgical intervention. And we have evidence, this was, I think, in the early days when tofacitinib was actually developed. Tofacitinib actually has benefits in terms of reducing, inhibit progression of structural damage, especially in those with methotrexate. You can see from the SHARP score, the erosion score, and the joint space narrowing, there's actually improvement on patients being on tofacitinib plus methotrexate. But what about in terms of preventing? What if she had an MRI accessible at the start? We know that previous studies showing that ultrasound treat-to-target therapy might be as equal as conventional treat-to-target therapy. And this latest study, whether an MRI-guided treat-to-target strategy would actually improve remission and less progression. Well, the Imagine-RA study looked at this. So patients had MRI of the dominant hand every 4 months for 2 years. They were targeting whether there's presence or absence of osteitis, and it should have a combined clinical remission of DAS 28 CRP of less than 3.2. But this study did not show any improvement. It was a negative study. There was no improvement in terms of remission rates or reduction in radiographic progression when we use MRI-guided treat-to-target therapy. And finally, in terms of tailoring treatment in rheumatoid arthritis, we have to consider right medications for the right patients. We have to consider what prior treatment failure. These has to come into considerations. Whether they have primary or secondary loss of response, the aspect about manifestations and comorbidities are also something that we should consider, especially in patients just now who has rheumatoid arthritis, ILD. Also with the use of JAK inhibitors, we have to be aware in terms of elderly RA patients and also assess the cardiovascular risk. And finally, the patient preference, communication is the most important thing. And the most important slide which I have today is this APLA 2027, which will be in Kuala Lumpur in exactly 2 years from today. And we have direct flights from Lahore to Kuala Lumpur. So I would like to invite everyone here, attend Kuala Lumpur in 2 years' time, not just for shopping or sightseeing, but also to attend the APLA 2027 Congress. And with that, thank you very much.
Thank you so much, sir, for such an insightful talk.
Our next keynote speaker is Dr. Babur Salim, Associate Professor and Consultant Rheumatologist at Fauji Foundation, Hospital, Rawalpindi, Pakistan. Dr. Salim is well-known figure in Pakistan Rheumatology Committee, known for his clinical acumen and commitment to improving access to quality rheumatological care in resource-limited settings. Please join me in welcoming Dr.
Assalamu alaikum. Am I audible? I think a talk after the meal would be most likely a postprandial talk. And I think that there's too much of the bombardment with the scientific knowledge. So my talk is not much of the scientific talk. It is more of a chit chat. So while I was having a conversation with Mr. President, Dr. Ahmed Saeed, thank you for this opportunity. I said that I can talk on any topic related to rheumatoid arthritis. And he said that keeping your personality, keeping your face looks, and keeping your financial issues, I think that this topic suits you. Rheumatoid arthritis, the challenges in developing countries. So I'm going to talk about well, we all know that we are dealing with a disease which is not only confined to the joints. It can involve any part of the body, no matter its skin, eyes, lungs, and we have already learned a lot of scientific product. I won't go into the details, but having said so, a disease, a little bit background, has an impact on almost everything, no matter it's a physical function, body pain, emotions, quality of life, everything is being compromised as compared to the general public. And if you see the mortality rate, these are all the studies which are being done in developed society, not in the developing society. And all these patients were in the treat to target zone, and yet the mortality is 1.5 times higher as compared to the general public. And the survival time is also reduced by almost 1 year. And irrespective of the fact that we have so many treatment options, including the JAK inhibitors, biologics, yet if you see that only 50% of the patients achieve remission with the conventional synthetic DMARDs. And almost 17% of the patients, this is the data from the BSR, and it's found that almost the remission with the first biologic or the JAK inhibitor is only 17%. And if we move on and on, the remission rates are reducing. And difficult to treat rheumatoid arthritis, as one of my friend has said, is around 5 to 20% of the patients are in the zone of difficult to treat RF. So this is the background of this disease. My topic is going to start with now that what are the diagnostic? These are the 4 objectives I'm going to discuss. One is the diagnostic delay, therapeutic delay, some possible solutions. These are probably anecdotal solutions, but I'm happy to have the suggestions from our seniors, colleagues, and the audience. So if we talk about the delay, so it's a non-scientific talk. It's a more of a gup-shup and chit-chat kind of talk. And if we talk about the delay is either at the level of the patient or either it is at the level of the physician. And if we see the prevalence of rheumatoid arthritis almost worldwide, it's almost 1%, which is with a 3:1 ratio between female and male. So let's come to some real world data. These are the community-oriented programs, and if you see the prevalence is in Pakistan is around 0.6%. And these are the areas. These numbers look very small, minute, but if you see the size of the population, the rheumatoid arthritis prevalence is exceeding 1 million in many countries, including Pakistan, and exceeding around 4 million in countries like China and India, which is huge. And if we see the number of rheumatologists in Asia, this is some of the data. If you see the number of rheumatologists and then the number of burden of rheumatoid arthritis patients, it's almost one rheumatologist has to see almost more than 10,000 rheumatoid arthritis patients, which is huge because in developing countries, either we do not have a rheumatologist, and if by chance we have a rheumatologist, they don't have to see only rheumatoid arthritis patients. We have to see other patients as well, including lupus and so many more diseases. So that's another issue is the limited number of rheumatologists and the burden of RA patients per rheumatologist. And here comes some good news. If you see the number of training centers, only in Asia, there are only 3 centers which have training centers more than 5. And I'm glad to know that in Pakistan is one of the highest center of producing maximum number of rheumatologists per year. Presently, we have almost 17 centers which train rheumatologists. And India has, by the way, the maximum number of training centers, but the population size is huge. And all these countries, including Nepal, Singapore, Sri Lanka, Abu Dhabi, Kazakhstan, the centers are less than 5 maybe. So we need more centers. So if you see the combination of all this, including the disease burden, limited rheumatologists, limited training centers, all these things lead to this part, that is the diagnostic delay. And if we see an average diagnostic delay in different Asian countries, I've included China to compare for its comparison because China is a bit more stronger as compared to the other developing countries. And if you see the average delay is around 1.5 years just to make a diagnosis of rheumatoid arthritis. These are the references of from different countries. And we know that the average diagnostic delay is 1.5 years, and around 70% of the patients have some kind of radiological damage within the first 1 to 2 years. That means most of the patients, when they get a diagnosis, they are already having some kind of radiological damage. So that's one of the proof that there's something going wrong at our end or maybe at the patient's end. There are many other causes which contribute to the delay, including the geographical barriers, cost of the treatment, myths, and inadequate referral system. I'll just give you one of the examples. This is the real-time example. Sometimes in Pakistan and even many other countries, the roads are being blocked because of the security reasons, and we expect a patient to come on the appointment day, which is nearly impossible. Sometimes there are no roads in developing countries. And sometimes this is the real time when the cloud burst was there. And how can we expect a patient to come on the appointment day when there was a cloud burst and all the roads were being like this? And sometimes the roads are being blocked by snow, sometimes like this, and sometimes in some cities there is no public transport system. So it's really difficult to expect that the patient would be coming to your clinic on the given appointment. And if we talk about the cost of Asia, the GDP per capita income of Asia versus Europe is almost less than half. It's around $45,000 in Europe, and if you talk about the Asia, it is around 21,000. It's less than half. So that is a big issue. And if you see the GDP per capita income of different Asian countries, all these countries have a GDP per capita income of less than 3,000. Unfortunately, which includes Yemen, Pakistan, Bangladesh, Pakistan, India, Nepal, Afghanistan. So with this kind of geographical barriers, cost issues, we have to think beyond how to treat these patients. Furthermore, nonetheless, we have myths at the level of patients. Patients don't believe our treatment sometimes. They have wrong beliefs, alternate cures, and underestimation of the disease. So the possible solutions, although these are possible solutions by me after working in rheumatology for around 15 years, I think that we need to have some target areas. This is what I see, that target areas, maybe we can target the 6 most important areas of the general public. Medical students, residents in internal medicine, non-rheumatologists including general physicians, physiotherapists, paramedics, and rheumatologists as well, and how we can guide the rheumatologist, I'll talk about. So regarding the general public, there are 2 ways. Either we can go for a social media or we can go face-to-face face. And if you talk about general public awareness program, if you're talking about it at a bigger level, we have to be aware of which social media is working in which specific country. For example, WhatsApp doesn't work in certain countries and WeChat doesn't work in certain countries. So we have to be knowing which target area, which general public we are trying to contact. In Pakistan, we do have WhatsApp groups, we do have Facebook. Twitter sometimes works, sometimes does not work. So we have to use a proper social media which can go longer and longer way. And if we talk about the face-to-face, these are some of the examples of public awareness programs in the form of door-to-door campaigns. These are few of our colleagues working in different setups. And this is one of our very good colleague, Hemanta from Sri Lanka. And these are some of the examples of our colleagues giving interviews on the television regarding awareness of arthritis. Okay, if we move on, the awareness prior to becoming a rheumatologist, this is the three most important areas. That is the undergraduate level, internship level, and the rotation in the internal medicine. This is so important because if they won't see it, they won't know it, and if they won't know it, they are not going to come into this field. So unless and I'm glad that Professor Ahmed Saeed has given a grant to our Fauji Foundation students for coming to attend this conference. And 6 of our students are here, and out of 6, 4 have decided to come into rheumatology. So the point here is that you have to show them what is rheumatology. They should be knowing what is it. Then probably they would think that probably it's a good field. Because if you're bypassing all these areas, suddenly they can't become a rheumatologist. They would definitely like to go for a more glamour field like cardiology or maybe something more. So if you see the curriculum at the undergraduate level in different countries, because we are talking about Asia, if you see in Pakistan, it's a good number of hours for the undergraduate. But the problem is this is optional. And unfortunately, in most of the countries and most of the cities in Pakistan, there are no rheumatologists. So the governing body can't dictate that you must have a rheumatologist at the moment because we are less. So similarly, in Sri Lanka, it is around 40 hours, Bangladesh 37 hours, Nepal, India, Hong Kong, the rheumatology is not yet mandatory at the undergraduate level, and in Iraq, it is around 44 hours. So this is a glimpse of the number of hours being taught in medical college for rheumatology. So increasing the number of hours, making few hours at least mandatory, creating awareness about the field, demand and importance, I think probably that could be helpful. And if we talk about the non-rheumatologist level, again, this is a very important slide because making a rheumatology, almost 10 rheumatologists are being made every year in Pakistan. And if we, after a period of 10 years, probably 100 or maybe 150, that is not good enough. So we need to involve our non-rheumatology people. For example, teaching how to diagnose rheumatoid arthritis. We must have some local guideline, at least to dictate when to refer a patient to a rheumatologist. Use of telemedicine, I don't have much of the experience, but it is an important tool. And teaching demand monitoring, especially for the remote areas, especially the patients who have geographical barriers. At least we can teach them, the physicians, the GPs, that how to monitor the side effects of the DMARDs. This was one of the project we got. One of my colleague, Fariz, had the grant from ILAR, and we taught the non-rheumatologists how to make an early diagnosis, when to refer a patient, and when to refer a patient who has a typical history, and when to refer a patient who has an atypical history. Well, moving on, awareness at the level of paramedics. Can you see this picture? If you see a very important person, we all know is the nurse. And unfortunately, we all know, we acknowledge her importance. We know that without this, we cannot move on. But unfortunately, the rheumatology nurse is not in our team, in most of the centers at least. So unfortunately, we do not have, in most of the countries, we do not have a structured training program for the nurses. So we need them in our team. This is one of the course. If Beneath is sitting here, I can see. No, I can't see him. Beneath is is a rheumatologist from Nepal. He's the third rheumatologist, and he's launching an online course for the nurses. And there is a good news. This is the first structurally formed nursing diploma course by Fuji Foundation Hospital, Rawalpindi, where I work. And we have our very first nurse, Huma, and Huma is right here, sitting here. She has an abstract and a poster as well. And we have taught her how to do the monitoring, how to diagnose, how to start the treatment. She is not allowed to prescribe, but we have taught them how to monitor the side effect of the medicine. She's doing well. So moving on, that's not the end of the story. The awareness at the level of the rheumatologist is very important. The problem is we are producing rheumatologists. That's the good news, the maximum number of training centers. The problem is half of them become trainers and mentors. And the further problem is, no matter because of the hospital issues, because of the government policies, only very few succeed in making a training center. So what to do? I've been training for the last 1 decade in Fuji Foundation. It's a suggestion to our new rheumatologists that just become a trainer. That's very, very important. Make training centers. I know this is a very difficult step. Work on different pathways. If somebody is saying that you cannot become a trainer through some pathway, in Lahore and in Islamabad, PIMS Hospital, they have started a MD program in rheumatology as well. So choose another program, but keep on going. Emphasize on the shared decision between the patients and the family. Always try to go for a cost-effective treatment, at least if the patient cannot afford. Because if you're giving an expensive treatment, it can't go more for years and years or maybe months. Patient is not going to come back to you. And definitely have a liaison with the non-rheumatologists. Moving on to the therapeutic gaps, this is complicated because it's a separate talk. I'll just put this picture that we are seeing that people are not considering methotrexate as the first line. They are jumping on to sometimes leflunomide, or maybe sometimes they are jumping on JAK inhibitors or more fancy treatment. So methotrexate is the first line treatment for rheumatoid arthritis. And I always say that remember 2 Ds, dose and duration. That is the most important. You cannot be treating an RA patient with a suboptimal dose of methotrexate and directly jumping on to something more fancy. So do not bypass the conventional synthetic demands. Inadequate screening is again an issue which has been risen by many of our colleagues. Underdiagnosing, under-recognizing the side effect of the treatment is again a challenge for us, and less emphasis on drug adherence. These are few of the challenges of the therapeutic gaps, but I won't go into the detail of all these gaps. I would just highlight a little bit about therapeutic gaps. This is a bridge between underdiagnosed comorbidities, and I would like to tell few of the possibilities. The gap is, first of all, the underdiagnosed cardiovascular system. We all know that cardiovascular diseases are doubled in rheumatoid arthritis. And one of the reasons is the higher disease activity. So we have to treat the high disease activity. That's the most important point. And please, at least screen these patients at least once in 5 years as recommended by the EULAR recommendations. And if we talk about further underdiagnosed comorbidities, another part is the osteoporosis, which is around 27% as compared to the general public, which is around 18%. And unfortunately, we do have the recommendations of glucocorticoid-induced osteoporosis, but we do not have any guidelines of osteoporosis in context to rheumatoid arthritis. So do you think that rheumatoid arthritis can cause osteoporosis? So if you say yes, please raise your hands. Yes, we all know that it can cause osteoporosis, but unfortunately, we do not have any clear-cut recommendations. So we must be having more recommendations. And another thing is the underdiagnosed depression. Again, it is far more common in rheumatoid arthritis as compared to the general public. And again, we do not have any recommendations. How to diagnose, when to refer, it's all blank, it's all anecdotal. I feel that she looks odd, or maybe she's so annoying. Why don't you go there? So there are no clear-cut guidelines when to refer these kind of patients to a psychiatrist or maybe psychologist. No guidelines. We need them. So this is going to be my last slide, that there are many more challenges. Low drug adherence, pre-RA treatment, should we treat or should we not? Limited head-to-head trials, treating rheumatoid arthritis in the background of active infections, underutilization of vaccinations, especially in Pakistan, and limited rheumatology seats is one of the challenges, because people are very much enthusiastic to become a rheumatologist, but unfortunately in many of the centers there's no seat, the way to go. So they're moving around, going to some other countries, maybe Dubai, maybe UK, and maybe Canada. So I would conclude that don't run away from the challenges, run over them. Thank you very much.
Thank you so much, sir.
Our next speaker is going to be Dr. Samar Al-Emadi, Senior Consultant Rheumatologist at Hamad Medical Corporation, Doha, Qatar. Today, she will be presenting on reproductive health in rheumatic disease patients. Please everyone, welcome Dr. Samar Al-Emadi to the stage.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizing committee, Pakistan Society for Rheumatology, Professor Nigat, Professor Sumaira, Professor Ahmed for the invitation, and being in the lovely country of Pakistan, and specifically in Lahore. So I don't have any conflict of interest. I think my job made very easy today, because Professor Asha Latif in the morning, I think she said exactly what I'm gonna say today, but in a different perspective I'm gonna say. So we'll take you through the consideration. What are the considerations to be taken in every single autoimmune rheumatic disease patient, specifically lupus population? So you need to plan the pregnancy accordingly in the way of a preconception, to manage the medication and potential risk, and to control the disease. You need to have a safety of the medication throughout pregnancy and also during lactation. And then you need to monitor the disease itself and to manage the disease itself during a pregnancy in the way of disease activity, obstetric care, and fetal monitoring. Postpartum consideration, again, flare of the disease can happen actually postpartum, and all of this should be done through a multidisciplinary approach. What are the risk stratification? In every single pregnancy, you need to do a risk stratification. Why? Because if you stratify your patient, then you will know what is the risk on this patient with regard to the pregnancy outcome itself, the disease itself, and on which basis you are going to stratify. First of all, the disease activity. Is the disease is active or not active? Definitely we need our dream to have a disease not active 6 to 12 months prior to the conception. Major organ involvement. Is it advisable to get pregnant or not advisable? Specifically if you have pulmonary hypertension, severe interstitial lung disease, severe renal involvement, it is sometimes contraindication to get pregnant. Maternal risk and comorbidities, things that we really usually we forget. Those days we are having aging population, so patient becoming pregnant older than before. So we have 40s, 45 up to 50 years that with all the new modality of the in vitro fertilization that they are getting actually pregnant. Diabetes by itself, arterial hypertension, obesity, all those are risk factors that we need to take in consideration with all our autoimmune rheumatic diseases, not lupus only. What about the previous complication? It's very important how the patient reacted or acted, or what was the outcome in the previous pregnancy. Did you have a normal delivery? Full-term delivery? Did you have a premature rupture of membrane? Small for gestational age? All of this is going to give you an indication what's going to happen in the next pregnancy. And definitely about the medication. And I advise every single pregnant woman, whatsoever her underlying disease, please do SSA, SSB. And all your connective tissue disease and in all inflammatory diseases, don't forget about it, because most of the patients are silent and asymptomatic. So we'll go through a case. This is a 30 years old Qatari female lady diagnosed with the lupus at age of 18. Her presentation was similar to any lupus, with just an arthritis, rheumatoid, malar rash, and leukopenia with positive serology. She was at that time negative for an antiphospholipid, but she was positive actually for SSA, SSB. Treated conventional treatment, hydroxychloroquine, azathioprine, and she was doing very well. Then, unfortunately, she developed lupus nephritis, class 3, treated with a small dose of steroid, rituximab, and then MMF. Then she went into remission. She got married, and she's planning a pregnancy. So before coming to my clinic to counsel her, actually, she lost her pregnancy at 8 weeks. And then we re-investigated her and was found to have positive lupus anticoagulant twice, 12 weeks apart. Other markers of her serology were just positive double-stranded DNA and with a normal complement. So she did not have an active disease, and now she's planning a pregnancy. So how you are going to advise her? Are you going to advise her to go ahead and get pregnant and to continue her Plaquenil azathioprine? Are you going to add an aspirin to that? Or you are going to add also low molecular weight heparin? Or you are going to tell her just wait. So just think of the case by yourself and see what you are going to do in your actual life. So what is important with this case? That she does have a triple threat. What are the triple threat that she does have? With regard to her maternal component, she does have lupus, so she may have a disease flare, or she may have a preeclampsia. Because she does have lupus anticoagulant herself, she can have a DVT or a thrombosis. What about the placental component? She can have, because of the antiphospholipid, she can have placental thrombosis and fetal demise. And also she does have a fetal component in the way that she's SSA positive, that she can have congenital heart block or later on neonatal lupus. What do we know about the predictors of outcome during pregnancy? And all of us, we knew the PROMISE study, but in the PROMISE study, they did not look at severe lupus or lupus nephritis. And what are the lessons that we learned? That lupus anticoagulant is the most powerful predictor of outcome. So we need to rethink how we treat our population if they are only lupus anticoagulant positive, and I can answer a lot of questions about this later on if we have time. Historically, lupus patients were flaring in the second and third trimester. But in PROMISE study, there was only 2 to 3% of a flare, which is actually not that high, and the risk was not really high. So a lot of live birth, around 85%. And this is very, very, very important that we don't prevent our population from getting pregnant just because they are lupus. So this is a huge meta-analysis done, and this is recently published in The Lancet, and this is going to tell you what are the odd ratio with regard any complication that you do have. For example, if you have secondary antiphospholipids, you have an odd ratio of 2.7 to have a pregnancy loss more than 20 weeks. If you have a previous lupus nephritis, you will have an odd ratio of 0.62 of a live birth. And if you have secondary antiphospholipid, the odd ratio is going to be a decrease of having live birth. You can have small for gestational age if you have an active lupus at conception with an odd ratio of 0.18. You can have a preterm birth if you have previous lupus nephritis, active lupus before conception, or by itself chronic hypertension. You can have lupus flare if you just have hypertension. So hypertension by itself is very, very important that you need to manage prior to the conception and during pregnancy. And definitely you can have preeclampsia if you have lupus nephritis, and the risk is really very high with an odd ratio of 3.1. So I'm going to switch to safety of medication during pregnancy because we do have a journey of recommendation. The first recommendation was an ACR in 2016 with an overarching principle. Then we had, in again, 2016, the BSR. Then we did have in 2020, actually, the American College of Rheumatology, which was the extensive review, and everybody was relating to that. And then we had again the BSR in 2022 that I found the BSR was a very stringent recommendation and more elaborative actually. Then we had recently the EULAR recommendation for the use of the anti-rheumatic drug in reproduction, pregnancy, and lactation. And this was in 2024, but the publication came early in 2025. I'm not going to go through this because everybody knew what is safe during pregnancy, what is not safe during pregnancy, but I'm going to stress on a few medication that really I need to highlight, which is number one is aspirin. We need to give all our pregnant ladies with lupus, I'm talking only lupus, that aspirin. And why aspirin is important? Because it decreases the risk of a preeclampsia during pregnancy. But in the general population, it was shown that elderly, higher risk of hypertension, prior hypertension prior to the pregnancy, giving an aspirin and the aspirin trial, which was published actually in the Lancet in 2020, showed decreased risk of complication for the normal population. But as we knew that all our recommendations, including EULAR, BSR, ACR, that you can give aspirin for lupus population, plus or minus antiphospholipid. But in other autoimmune rheumatic diseases, including inflammatory arthritis, we don't have an evidence that aspirin can do anything unless the patient is hypertensive. There is a very important placental anti-angiogenic factors, which is the split factor, because we do have factor endothelial growth, which is very important to keep the homogenesis of the placenta. And if there is an imbalance, and this happens actually with hypertension, that you can measure the split factor in the blood, which is easy to be measured. I don't have it in my hospital. I don't have any hospitals here. They do have it. And what has been found, this is a publication just 2 weeks ago, actually it was published, that analysis of the longitudinal behavior of serum level of the soluble split factor 1 and placental growth factor in a pregnant patient with lupus. What they found actually, that if lupus, if it's not a flaring, just normal lupus population, you do the split factor in the second trimester, that it's gonna predict that this patient is gonna have hypertension, which is a preeclampsia during a pregnancy, irrespective of disease activity. And this is the beauty. In the past, we really had hard time to differentiate between active disease and preeclampsia. Now we do have a study that it's telling us if you do this split factor that this is secondary to preeclampsia, this is not secondary to active lupus. And this is really an important because it's going to help us not to give the patient a lot of our medication, including prednisolone, that we don't like to give during pregnancy, because the risk of gestational diabetes, preeclampsia, and eclampsia is going to be really high. What about hydroxychloroquine? Why I'm going to talk about hydroxychloroquine? Because in 2021 early, we had the big deal of this study which came out, which is hydroxychloroquine early in a pregnancy can increase the risk of birth defect. And then the EMEA labeling actually for hydroxychloroquine was changed just because of one study that came out from the US, and they found that there is an increased risk of maybe congenital malformation of 25%. But there are other counter studies that came to assure you that hydroxychloroquine is safe during a pregnancy, with all the good things that hydroxychloroquine do for all our lupus population. And we came up with a global comment on the use of the hydroxychloroquine during preconception period and the pregnancy in women with autoimmune disease. I was part of this global comment, and it was published in the Lancet Rheumatology, that we are counter against that hydroxychloroquine can give anything, to reassure all the community that dealing with autoimmune diseases and the pregnancy that hydroxychloroquine is safe during pregnancy if you are not going a dose above 400 milligram. And the study was only in the American population. It was not done on the other population. And furthermore, there was a lot of studies came out that hydroxychloroquine is safe. What about the use of belimumab in a pregnancy? If you think of the structure of belimumab, actually it should not cross the placenta. Just as a structure, it is safe during pregnancy. But what do we have in evidence? We don't have a lot of evidence. We do have case report, and we have post-marketing data by Michelle Petrie that showed that in 319 Bilmab exposed pregnancies, there was a few congenital anomalies, but they were not consistent. And it can be sporadic, so we cannot say that Bilmab increased risk of congenital anomalies. And you can see that in the British Society of Rheumatology guidelines, they actually went through the Bilmab data fully, that you can use it if you don't have alternative medication to control the disease activity. But if you are going to give it throughout the pregnancy, you need to defer the vaccination 6 months post-delivery. What about anifrolumab? Actually, we don't have a lot of data about anifrolumab during pregnancy. A few case reports that did not show any congenital anomaly or safety issues during pregnancy, but at this stage, all the guidelines does not recommend giving anifrolumab during pregnancy. So what about if the patient is clinically actually is a quiescent, but by lab she's active and she's coming to you that she's pregnant? Do you allow her to get pregnant? Do you add more medication? Do you have any data? This is a nice study actually done in Japan looking at an active disease by serology, but clinically the patient is quiescent. And they showed that if the patient is not active clinically, they still can go through a pregnancy actually. But the most important thing is that the dose of prednisolone should be less than 7.5. I advise even 0 milligram per kilogram. So don't give steroid during pregnancy because the complication is going to be higher. What about antiphospholipid? Antiphospholipid, all of us, we knew the new classification criteria. Again, I'm going to stress something on this. It is a classification criteria. They are not diagnostic criteria, so they are made only for research. And there are a lot of debate about those new classification criteria of antiphospholipid, because even for the obstetric antiphospholipid, they did not define it very well. They forgot to say that if or. So there are a lot of mistakes, with all my respect for the authors of this, that I think that they are going to revise it and we are going to come with a better classification criteria. What are the obstetric antiphospholipids? That all of us, we knew the definition, but my advice that before blaming your antiphospholipids, please roll all the other differential diagnoses of recurrent pregnancy loss, including infection, including any anatomical abnormality, any hormonal issues, especially a short luteal phase, and or any other antibody positivities. Thyroid is very important. TPO, you need to rule it out, and then blame your antiphospholipid. And please look at the histopathology of the placenta. All of us, we knew that there are embryonic or fetal death around 38%, growth restriction usually, and preeclampsia, higher risk with people with antiphospholipids. There are specific histological features that usually I look at when there is a placental pathology in my clinic, just to be sure that this is the cause of the pregnancy loss, because there are like histological criteria that can go with decidual infection or other inflammation that you need to look for. Why? Because we knew that antiphospholipid is not only about thrombosis. There are a lot of inflammation and different stages that's happening. And you can have at the placenta, but also you can have at the decidua. So don't forget the decidua part, that it can have a lot of inflammation and this will lead to pregnancy loss. All of us, we knew how to treat a classic antiphospholipid, but what about refractory antiphospholipid? What do we have for refractory antiphospholipid? Actually, we don't have a lot for refractory. What we have small studies regarding small dose of prednisolone that you can use it from the first trimester up to third trimester, between 10 to 20 milligram prednisolone to overcome the last pregnancy loss. But in the study, they don't advise giving the steroid. Why? Because, as I said earlier, that the risk of complication is higher than the benefit of keeping the pregnancy. What about hydroxychloroquine? I love hydroxychloroquine, so I give all my patients hydroxychloroquine, and we have a few evidence that telling that it can improve pregnancy outcome. What about pravastatin? Pravastatin, it has been shown only in one study of refractory antiphospholipids because it improved the nitrous oxide at the endothelial level. And this is in combination between aspirin, Clexane, hydroxychloroquine, and a pravastatin. And usually we don't continue to throughout the pregnancy. You can start in the first trimester and second trimester. And this is like a scheme of how to treat antiphospholipids. You can go with the step 1, you go with your aspirin, low molecular weight heparin. If it fails, then you go aspirin, hydroxychloroquine, and low molecular weight heparin. Then if it fails, then you add your prednisolone to the above. If it failed, you can add IVIG, that we don't have a lot of study on this. Or step 5, you can add TNF, and we do have now a trial, which is the IMPACT, a trial that I'm going to go through it. And then maybe you can add pravastatin. So we don't have a lot. Still, we do have around 10% of pregnancy loss in antiphospholipid with regard to all the modality for treatment that we are having. With regard to the TNF, finally we have a study, which is a randomized open label study. This is the IMPACT study done by Jane Salmon. And they studied patients giving certolizumab starting week 8 till 28 of the pregnancy, and to see if there is an improvement in the outcome of the patient with antiphospholipids. And actually there was an improved outcome. Their conclusion was, historically we have 40% complication. They were looking at 20%, and this was achievable in this study. But be careful that not every single complicated antiphospholipid will respond to certolizumab, because my advice that I don't want people to overcome using the TNF, because we don't have a lot of data that it is not generalized in all population, that we need to wait to see more population. The number of the patient studies were only 44, and I cannot generalize 44 patients on all the population. I don't have time. So this is the IMPACT study. I'm not going to go through the neonatal lupus, and I just want to highlight that we had just recently a study about the insight into maternal and the neonatal antibodies implication on the pregnancy and the neonatal death in Qatar. So what we found that retrospectively, patients who received hydroxychloroquine after having a baby with congenital heart block, their second pregnancy, the rate was decreased, and we did not have any single mother with a neonatal congenital heart block after we reintroduced hydroxychloroquine. We were using actually 400 milligram in this study. And we had 75% live birth, and you can see that statistically that hydroxychloroquine was showing statistically difference, and actually vitamin D giving to the maternal, it was going with better outcome in the pregnancy. So take home message, educate your patient early and often. Know and recommend appropriate contraception that all of us we forget about. Rule out serious underlying disease-related damage. Timing is critical. We all wish them that 6 months that they are not having any active disease, but this is not reality. Review medication before pregnancy and change them accordingly, actually, which are compatible. And counsel patient and actually partner. Why partner? Because you need the support of the partner for the pregnant lady throughout pregnancy and postpartum, and the close monitoring with rheumatologist, obstetrician, and other specialty. And I advise all pregnant ladies should be taken care by a rheumatologist, not by obstetrician. Thank you.
For our next keynote speaker, we have Professor John Axford, Professor Emeritus and Professor of Clinical Rheumatology at St. George's University Hospital, UK. Today, he'll be speaking on personalized medicine in rheumatoid arthritis. Please join me in welcoming Professor John Axford.
Well, whilst he plugs me in, thanks very much for inviting me again. I must have done quite well on Wednesday, which is rather good. And I appreciate that the audience is quite full because you all wanted to see me in a kurtar. And I actually had a jacket last night, but I breathed out too quickly and the buttons all came off. So that will be for the next visit. My honorary mother down there didn't sew the buttons on quickly enough. But this meeting is fantastic, and it really is a great pleasure to be here. Isn't this meeting fantastic, guys? And such a privilege to be able to talk in these sessions, but this last session was just phenomenal, especially Dr. Al-Emadi doing all that in 20 minutes. Golly, but nobody overlapped. It was all complimentary, and it was all sort of very high class. Well, this is where it all stops. So, quite a few years ago, we all have to give a talk when you become a professor. So this was quite a few years ago, and the guy that went before me, this is just thinking about what this guy's doing here, he was on time for about 20 minutes, and we were given about 30 minutes, and then he got longer and longer and longer, and I thought, oh, heaven's sake, here we go. And he overran by about 10 minutes. And then he came to say goodbye, and I don't know how he did it, but he managed to show all my slides backwards, starting with the final joke. So you've actually all seen all my final slides there. And thank you very much for inviting me here. What we're going to discuss this afternoon is personalized management for rheumatoid arthritis, and I'll try and explain to you what that really means. And the title here is Moving Beyond One Size Fits All, i.e. one protocol is all we need to manage our patients with rheumatoid. So we are told, and we think we've got a bit of a trial and error approach here, and it is said that RA is a complex disease that varies from patient to patient. We've got many treatments, but it's hard to predict who responds to what and in the best way. And we're told that this leads to a time-consuming treatment plan for patients, and sometimes patients get quite frustrated by this. And our goal, which we haven't quite found that, is to find the right drug for the right patient at the right time. So just to test our sort of feelings here and sort of get you awake at 4 o'clock today, who actually feels clinically in the clinic when patients come at the right age, around about 35, female, etc., that rheumatoid arthritis varies a lot between patients to patients? You think it varies? And who thinks that it's pretty barn door when a 35-year-old lady comes in with rheumatoid? Well, obviously, I'm in the minority. Your patients are different in London. Who actually thinks it's that we have many treatments and we can't work out what to use first line in our patients with rheumatoid arthritis? And to say that the other way around, who's happy with methotrexate? Good. Do you feel that when you start your treatment with patients, because you're actually using methotrexate, you're using a drug that you have confidence with, that this becomes a bit of a time-consuming, frustrating problem for the patient, or generally it's successful? So we've got 2 hands up here. Who has no success with methotrexate, i.e. 50% of their patients fail methotrexate due to efficacy, not because they feel ill? So we're in a bit of a dichotomy here. We've got 2 people say that they don't like methotrexate, and a few people say that, yeah, in my clinic, methotrexate is very, very satisfactory for the majority of the patients. The majority of my patients that fail methotrexate is because they feel ill when they take it. And usually this is for late onset rheumatoid arthritis. So we have a little bit to discuss here. But this is how I've summed it up here. RA is complex. Well, yes, it could be, but not much. We've got many treatments, but I reckon that if we use methotrexate, sulfasalazine used to be a favorite of mine, but it's gone out a bit out of fashion, and a biologic, so that's 3 drugs. I'm 95% happy, and so are my patients. So I don't think we've got problems with our management. I make things a bit faster for patients by adding prednisolone, and they tend to like that, and that's, in my feeling, is it helps methotrexate work. The goal is to find the right drug. Well, I reckon we generally do find the right drug in our patients within a 4 to 6 week period. So my discussion point here is I don't think we've got a major problem on our hands. What makes me very envious is that Chris Denton has an awful lot more disease markers than we do and can use these disease markers when he looks at his scleroderma patient to predict those that are going to have problems. And I'm very envious about that because we don't necessarily have that in our with our patients. So the next test here, just to sort of keep you awake here, just shout out at me when you're making the diagnosis of rheumatoid with your patients and disease and thinking about disease activity, what things are you looking for and managing? So hands-on, what are you looking at? Well, you're just touching the whole thing, aren't you? It becomes automatic after a few years. So hands, wrists, elbows, shoulders, what hurts, what's swollen, etc. So you can work out the clinical diagnosis with your hands. Your hands are more powerful than an MRI machine. What are you doing blood-wise? So you're doing it's quite simple, isn't it, to tick a blood form for rheumatoid. You're doing an ESR, a CRP, physiology measurements, and rheumatoid factor is so old-fashioned, but rheumatoid factor, CCP, that's about it, isn't it? You don't have to do anything more elaborate. Imaging, imaging, tick the box there for imaging. Ultrasound's the easiest but the most expensive. MRI takes the most time, but is generally the cheapest in the UK. I don't know what it is here, but MRI imaging. So these are the biological clues that we use, okay? Pretty minimal. What we think about our patients, is it top and bottom? Is it the whole upper and lower limbs, jaws, neck, etc., or just hands and wrists? Our biomarkers are exceedingly limited. 10 years ago or 15 years ago, I used to measure DR4, but that really didn't help me very much. We can't get tissue. There are people that do tissue biomarkers there. Antibodies here, you'll notice that is an immune complex because there are 4 immunoglobulins. They're all linking. That's the logo for my rheumatology clinic. We used to get big into IgA rheumatoid factor in years gone by, but that's gone out of fashion a little bit. So we're just looking at CCP. Way back, in my lab, we started looking at glycosylation of immunoglobulin G and found that we could link that with rheumatoid arthritis and other autoimmune rheumatic disease. Well, that remains out there in the literature, and that first paper was published in JCI in 1992. Imaging, we're not that demanding, are we? I don't do many x-rays, but ultrasound, MRI, if I get really sort of going for a PET scan, but usually that's if you think somebody's got, my arm's not long enough. It's usually when you're working out somebody has or hasn't got JCA. So a tailored clinical response here could be personalized treatment considering a patient's unique genetic, clinical and lifestyle characteristics. And we've had much on lifestyle, which is rather interesting here. And then you're identifying and putting patients into subgroups. And this should allow you to select the most effective therapy from the start. But as I've gone through, your clinical variation isn't very much. The drugs you've got generally work pretty well. So I generally don't sort of go through these things methodically at the end of a clinic, working out whether I'm using the correct medication. Dan Sager will tell us tomorrow whether, because of my dissatisfaction with all this, you can put all that data we've got in blood, imaging and everything else into machine learning, deep learning, and multi-scale modeling and see whether it comes out and helps you anymore. Would be interesting, wouldn't it, to see whether we are missing something special. So this is something I patented in the UK. This is my weather forecasting stone, you see. So the stone's dry when it's not raining. You can't see the stone when it's foggy. and the stone's gone when you've had a tornado. Well, we could probably put this into rheumatoid arthritis. They don't have rheumatoid arthritis because they've got a rheumatoid factor that's positive, but they're totally normal. That's one of the more common referrals into my clinic. You've got late onset rheumatoid arthritis when it's foggy. They have a lot of pain, but they don't have much synovitis or joint swelling, or they're young, unfortunate 35-year-old ladies, and all their joints are painful and swollen. I'll put that into a sort of pattern over the next few years or so. So categorizing degrees here, we're trying to divide our patients into clinical types based upon antibody, disease activity, joint damage, which we can do. This will help us guide us through initial treatments, because there have been some innovations and some recommendations that we can actually use looking at antibody positivity, negativity, etc. And although we were told just now that the recommendations are not to stop treatment, all patients want to stop treatment, but how do we know they've actually gone into remission? How do you know that the disease has switched itself off? A difficult one. So the reality is, sometimes we find it difficult to diagnose disease. I'm sure you have an awful lot of patients come into your clinic that have got inflammatory osteoarthritis diagnosed as being due to rheumatoid arthritis. And we find it very difficult to predict those patients that are going to have a rough time and those that are going to just sail through it, get under control within 8 weeks, and off they go on 6-monthly follow-up. So I'm just going to show you a few clinical cases here, and one or two of these complement the clinical cases we've had before. Just the problems that exist in the clinic, and I'll say it a couple of times. Someone told me that to get over a message, I need to say things 3 times. But the bottom line here is we're missing the link between our patient, the diagnosis, and how we can predict where they're going and what the pathway is that they're going down. So this is Ronnie. She's 27. She was diagnosed with rheumatoid arthritis in 2020. She's CCP positive, and she also has a bit of other autoimmunity going on here, ANA positive and JO positive, but no clinical features of another autoimmune rheumatic disease. But in that period of time, 5 years, I've gone through methotrexate, hydroxychloroquine, and I can't say all these things, badasitinib, Cimzia, Tofa, baricitinib. I was actually sort of coming to the last paragraph and up to date in what you do when you're really stuck to manage your patients. So I took a deep breath and we thought, well, let's try rituximab. And that works really nicely. She's on her 4th cycle, and the separation between treating her has gone from 4 to 8 months. She's very good with the disease. She knows when it's coming back. She gives me a call, and you don't want to get into using rituximab when patients are having a flare. But so what's so different about Ronnie? She just looks like a typical young lady with active rheumatoid arthritis, principally affecting her upper limbs. So this is a slightly older lady. I saw her when she was 40, right back in 1995, and she was again CCP positive, took her through methotrexate, and she was one of the lucky ones, wasn't she, in 1995 to have adalimumab. I think we actually started her on infliximab, if you can remember that. Did very, very well. And in 2023, she got endometrial carcinoma with metastases, and she was really unwell for about 18 months or so. And she had surgery, she had chemotherapy, radiotherapy, carboplatin, paclitaxel, bevacizumab. And she slowly got better. Her adalimumab was stopped throughout all that, and she's in remission. She's been in remission for about 18 months now. What's caused the reset in this patient? Now, I have a number of patients like that, and I'm sure you have, but where's rheumatoid arthritis gone? I'm not suggesting we should treat everybody with these drugs, but we're missing the crucial link here. How have the oncologists reset this patient's rheumatoid arthritis? And this is a nice chap. He comes along every 6 months or a year and has a chat with me about canoeing. Straightforward, rheumatoid arthritis in 2010, unwell, upper and lower limb involvement, significant reduction in quality of life, daily activities, etc. Methotrexate worked a wonder, came under control in 6 weeks, took him off his corticosteroids. Some of this was, in fact, treated during lockdown, which was quite interesting, but that's another lecture. And he wants to come off meds. Well, in fact, he doesn't. I say, well, let's try and come off the meds. And we sort of get him down to 50 milligrams, 12.5 milligrams, 10 milligrams. And every time we stop it, it comes back. But I can't detect that. I do an ultrasound, I do a blood test. Yeah, how do we get into that immune system to work out that that disease is just waiting there to switch itself on again when the last milligram of methotrexate is stopped? How do I predict these people? How do I treat people? So a brighter future for our rheumatoid arthritis patients. We want to try and improve outcomes. We want to try and reduce side effects. And we want to try and be more cost effective. That's what our aim is. But if you look through what's out in the literature now, it really is pretty dismal. I don't know whether you saw the editorial by Peter Taylor, and he had Gert Burmeister and Joseph Smollen, so you got three pretty knowledgeable guys here, towards better personalized care in rheumatoid arthritis. It made really depressing reading. Peter had nothing new to say apart from what I was practicing in 1986 when I was a junior doc at King's College Hospital. Joseph Smollen, who I know got a multi-million pound grant in the early 90s to look at cytokines and predict rheumatoid arthritis, and one didn't hear any more about that. But his review spoke about rheumatoid factors. It's something that we were talking about back in August 1985 when my colleague here, Raj Parekh, Raymond Dweck, and Brian Sutton published in Nature that there were sugar changes in both rheumatoid arthritis and osteoarthritis, but specific ones in rheumatoid. And then we went along and looked at all sorts of different diseases and worked out ways of doing his a glycosylation test by sugar printing, and this went into JCI in 1992, but we could differentiate a whole load of rheumatic diseases using our sugar printing technique. So this just shows that we've actually haven't moved forward since 1990, which is pretty depressing, isn't it? So maybe we should just sort of go and do it, as my children say, just do it, Dad, and maybe we should. The bottom line here is, and I'll say it again, we should actually try and use what we've got. So this was an interesting lecture that Paul Emery gave at this year's ULAR, in fact, this year's BSR, and it was a really good talk. He called it his rant, but basically, whoops, where am I going here? Something's gone wrong there. But what Paul has said here, and hopefully some slides will come up to show that, was do we need to stick to what we've been told about protocols and stick to methotrexate? Or if we're concerned and we have this sort of clinical instinct, should we not sort of skip methotrexate and move on to biologicals straight away? Remove the shackles that our health service puts us through. And I think this is one of the examples where this is interesting. I've managed to make a slide that comes out like this. Things you can do at midnight. So his advice was, why don't you consider biological first-line agents first? Wow. We need to have higher remission rates. They can be achieved by doing this, and he produced some very interesting data showing either biologic on its own or with methotrexate. And it makes logic, if we really don't know how to predict what's going on, to use the best available. So in certain patients, and I had a 15-year-old girl with really bad ankle and midfoot synovitis before I came out. I thought rather than putting a 13-year-old through methotrexate, she's gone straight on to adalimumab, and we'll see what happens with her. But I think we can actually take treatment into our own hands these days and not exactly follow our protocols. So maybe you'll read Paul Emery's papers about this and decide to sort of move on. Or maybe you're in an environment where you don't have to follow a protocol, which would be fantastic, wouldn't it? So what else can we do? So lifestyle and clinical factors. I'm expecting a question from the audience on lifestyle. Holistic care. Patients love holistic care. And they said, you're the first person that's only spoken to me about other things other than my hands. And maybe this is person-analyzed care, focused upon the person. So patient-specific factors. You want to think about what's going on with the patient and where they are in the environment. It's amazing how patients that are in control get lost to follow up. And when they come, talk to the patient and examine the patient. Every time they come, talk to them if necessary. I've got Ali Abbasi who sits above me on Tuesdays, and I send the patients up for ultrasound, and sometimes the instinct is right. Just ask the patient what they want. Sometimes children don't like tablets, sometimes people don't like injections, and you just want to make sure you're not going to give them something that they're going to dislike. I'm running out of time, but I am actually the last speaker, aren't I? So I can go on forever. Comorbidities, I think we need to know an awful lot more about diabetes, cardiac disease, etc. And where the patients live, because you may think certain areas of where you live is a bit of a desert, but certainly there are quite a few deserts in the UK, and an awful lot more can be thought about that. So we can actually use an awful lot about what we know already to actually improve the outcome of our patients. And I'm just going to, if you'll just give me a few more seconds, I think you may enjoy this. Sometimes a patient comes in through the door and you go, oh, heaven's sake, what has gone on here? And this lady who was born in 1960 came in a mobility scooter. She hadn't walked for about 5 years or so. She was young. In 2006, they diagnosed her with rheumatoid, elbows and hands, started her on methotrexate, and she gets put into, they're great, but a nurse-led clinic, and these nurses are seeing 30 patients per session, and the patient comes in and says, how are you? She says, I'm doing all right. Then off they go, they get another prescription for methotrexate, and that had been going on since 2006. What the surgeons didn't report was that they'd given her a right total hip replacement, a left total knee replacement in the intervening time. She stopped methotrexate herself in 2024 because of her teeth were falling out, and so was her hair. But it's not the patient's responsibility to sort of think, well, this is a bit of a disaster, isn't it? Let me go and find a doctor, but they don't even know how to find doctors. And if they phone up our hospitals, no one really answers the phone. She came and saw me in May. Significant deterioration. This lady was on the way out, and hip, hands, wrists, shoulders, knees, and particularly her right hip was just she was in excruciating pain. So this is where you use personalized management. You ask her what's going on, what the problem is, what happened here, etc., and then talk about appropriate treatment and talk them through what we're going to do to get her back as far as we can to normality. So she's got 2 hip replacements here, but no, there we are. So we replaced her left hip. Surgeons were really quick in doing that. Corticosteroids, put her very quickly on adalimumab because obviously she'd had a bad time with methotrexate, and pain, swelling and stiffness resolved. The left hip was just magnificent, and she's increasing her activities. So this is what she looked like when she came in. Someone was saying to me, we don't see traditional rheumatoid arthritis hands, do you? You do sometimes. And look at this, swan neck deformities, ulnar deviation, fixed fused wrists. Look at that knee, fixed flexed. knee there, etc. You know, total disaster. And the lady was just sort of wasting away.
Prof.
She also has
Axford.
osteoporosis, by the way.
Excuse me.
And I'm just
Prof.
going to show you this one thing. Sorry, guys, this may work. Last time I did a video here,
Okay.
disaster, and this just made my day. Are you going to move? Go on, move. There we are. So this woman hasn't done this for 10 years, and that really made my week. There we go. That's what personalized medicine is all about.
Thank you.
So I hope you get the message there is, so a personalized approach, do better with what we've got is my recommendation. Make sure you've got the correct diagnosis, keep questioning yourself about what's going on, take your patients to MDTs. I have a WhatsApp group for radiologists and rheumatologists. Get the patient examined, examine the patient at each time, and then find a friendly MSK radiologist, and have a detection method for making sure that your patients don't get lost to follow-up or don't get lost to nurse and GP-led clinics where if a patient says yes, then they get say, well, we'll see you back in a year's time. This is the team there. This is my thank you, Shukriya, for having me and for being so attentive. And what I also want to say is, guys, thank you for putting on this fantastic weekend meeting. It's a privilege to be here. This is the first one I came to in 2018. We had lots of teaching initiatives going on, which I think we need to resurrect. These are the lovely people that I've met during my time and the people that have kept me happy. People invite you into your own homes to say, come and have dinner. You know, I'll try and do that in London. And look at this. This is where you've come since 1997. And I think it's phenomenal. I'm going to work out what we were like in 1985, etc. So thank you again for really telling us how to put on meetings.
Thank you. Well, thank you very much to all the speakers. I'd like to inform that due to constraint of time, we are not taking questions and answers. So if people are interested, they could tag along the speakers and ask them the questions. Thank you very much, Prof. I am also been given the task to round up this session. We had some very interesting talks, starting from Dr. Fariz, and he shared with us some specific cases highlighting the need for individualizing treatment for each of our patients based on what they learn and how they respond to therapy. Dr. Babur Salim highlighted the challenges, and the good part is that he also provided some solutions, and we were really excited to hear how we are doing much better than what we were in the past, and Godspeed to him and his team to work with the nursing training program as well. So that was exciting. Dr. Samar, Al-Emadi, your talk was very interesting. It was reinforcement of how we should look at the pregnant population as a very separate subset of individuals who require very specialized stratification and treatment modifications. And you also highlighted the need for aspirin, hydroxychloroquine, and the complex issue of antiphospholipid syndromes. And that was quite a interesting learning opportunity for most of the audience. Professor Axford, I was also happy with your roundup of the condition. And as you pointed out, we are usually working on trial and error and see what works for our patient and then switch on to sequential therapy. I would like to possibly imagine that, like oncologists who do gene sequencing, cytokine analysis, and determine which drug would be the most appropriate drug to choose for our patient. So we should go that way because we have now a spectrum of diseases which we know as multimodal. They might be having different pathways more prominently affecting in one individual rather than the other. So thank you for bringing that to light, and we hope that you had a very fruitful session. Thank you once again to the organizers and the audience for being here till such a late time. Thank you very much, everyone. Have a good evening.
Thank you so much to our speakers and our chairs. Now I would request the worthy chairs and co-chair to present a token of appreciation to our speakers. So please, for that, kindly, can you guys please come on the stage? So first of all, we have Dr. Fariz Yahya. I would also like to call Dr. Rafakat on the stage as well to please give the souvenirs. And Dr. Messam as well. Next souvenir will be given to Professor Babur Salim. Okay. Next up we have Dr. Samar Al-Emadi. And lastly, we have Professor John Axford. Now I'd like to request Dr. Messam Afzal and Dr. Rafakat Hamid to present a token of appreciation to the chairs of the session. First chair will be Professor Kamran Hamid. Secondly, Professor Samina Ghaznavi. And lastly, Dr. Yasir Imran. Thank you so much, our speakers and our chairs. With that, our plenary sessions for today comes to an end. We'll begin our intensive imaging workshop at this venue immediately. Whereas in Crystal Hall A, we have an MDT session featuring the Rheumatology and Dermatology Board taking place as we speak. Please note that the PSR Council members meeting is taking place in Pearl Boardroom as we speak right now. Thank you so much, everyone. And that